So the master study was conceived about 4 years ago, as we foresaw the fact that the advent of monoclonal antibodies, as well as the development of newer proteasome inhibitors, was bringing to myeloma really a unique opportunity. There was the opportunity of drive the majority of patients into a deep remission. And while continuous therapy had been the standard in myeloma for quite a few years, we believe that had to be reappraised in a different setting where now most patients can achieve a deep response. At that point, minimal residual disease, particularly by next generation sequencing, was becoming better understood. So we conceived this study in collaboration across 5 institutions, forming a consortium to really deploy the best available myeloma therapy at the time, including autologous transplant, be able to tailor the duration of therapy to the achievement and confirmation of achievement of negativity of minimal residual disease, and then have a path to cease therapy and follow those patients longitudinally without the burden of continuous maintenance therapy. Yeah, so this was prospective phase 2 single-arm study where patients with newly diagnosed myeloma, including patients with an enrichment for patients with high-risk cytogenetics, receive quadruple therapy with Daratumumab, Carfilzomib, Lenalidomide, and Dexamethasone. Those patients did not have an age limit. We had patients as old as 79 in this study. And there was some eligibility details that allow the inclusion of patients who often present sick and are excluded from other newly diagnosed myeloma trials. Patients received 4 cycles of induction, had MRD assessment, received an autologous transplant, had another MRD assessment, and then they received 0, 4, or 8 cycles of consolidation with Dara-KRd. The duration of therapy was dictated by the MRD that is assessed at each of those blocks of therapy. If patients who had 2 consecutive MRD negative reads to less than 10 to minus 5 by NGS were then able to cease therapy after that last block that they receive and go on to observation with MRD surveillance, something we call MRD sure. For patients who did not reach that milestone and were able and proceed to receive the whole therapy, they then continue on standard of care maintenance single agent lenalidomide. It's important to emphasize that MRD was assessed by next generation sequencing using the clonoSEQ platform and was performed and reported using the international harmonization on performing and reporting MRD multiple myeloma trials. Yeah, so there was some important findings. I think one that is quite important but often overlooked is that this is doable. Even though we're working with 5 different sites, we are able to obtain trackable sequences. We're able to implement MRD guidance in 96% of the patients. And despite the multiple MRD testing, we had one single sample that was missing the whole study. And we always got results back on time to act for the next step. So I think that's an important part that is, near real-time MRD response adaptive therapy is feasible in that multi-institutional setting. In terms of the safety of the regimen, was safe. We had, of 123 patients, we had 3 deaths, 1 sudden death on the 2nd week of therapy, and 2 during the recovery from autologous transplant. We had usual neutropenia, thrombocytopenia. We had a few SAEs for pneumonia and deep venous thrombosis, but no other new safety signal. The regimen, the program was highly active. Overall, we had 80% of the patients achieve MRD negative to 10 to minus 5, which was the primary endpoint of the study. We also have 66% of the patients achieve MRD to 10 to minus 6, which was an exploratory endpoint. Overall, 72% of the patients reached the milestone of having 2 consecutive MRD to 10 to minus 5 and were able to enter the MRD sure phase. Importantly, when you look at, we reporting the results by subset according to cytogenetic risk. So we separated patients with 0 cytogenetic high-risk feature or standard risk, patients with 1 high-risk chromosome abnormality or high risk, and patients with 2 or more that we call ultra high risk. The responses and the MRD responses between standard high risk were nearly identical. Actually, in several circumstances, they were looked at actually a little bit better for the high risk patients. When you look at the ultra high risk, you have a kind of a different story. They have the same likelihood of overall achieving MRD 10 to minus 5, but that tends to happen later. And they have a lower likelihood of achieving MRD to 10 to minus 6. Among the patients with ultra high risk disease, we also had some early treatment failures. Actually, patients progressing on therapy while receiving quadruple therapy, and some other patients progressing shortly after discontinuation of quadruple therapy, which speaks to the really the bad behavior of this small subset of patients that is often underrepresented in clinical trials. In our trial, they're accounted for 20% because of the high-risk enrichment. Overall, for patients who had 0 high-risk abnormality, the 2-year progression-free survival was 91%. And for the patients with 1 high-risk abnormality was 97%. The overall survival at 2-year was respectively 96 and 100%. However, for the patients who have 2 or more high-risk abnormalities, the 2-year PFS was 58% and the 2-year overall survival 76%. We believe this speaks to the need to adapt therapy, not only to the cytogenetic risk, but to the depth of response. We have now the vast majority of patients with 0 or 1 high-risk abnormality doing well off therapy with reasonable follow-up. But it's pretty clear for the patients with ultra high-risk disease, particularly the ones who don't reach a deep response, how innovative therapy is going to be needed. Yeah, I think, we have to look for the study for what it is, which is a single-arm phase 2 study. So it's more of a precedent-setting, principle proving rather than definitive evidence. I think, for one, it shows the excellent activity of this combination, Dara-KRd, along with autologous transplant. Perhaps more important, it shows that we can instrumentalize MRD to enrich a subset of patients to then ask specific questions. So we believe in the very near future, we'll be employing quadruple therapy and then asking the escalation question for the patients who are early achievers of deep responses. But conversely, for patients who do not reach those milestones, particularly the ones who have a high-risk biology, we will need to experience with the introduction of agents with a different mechanism of action, And at this moment, that seems to be anti-BCMA agents. So I think we're going to be learning from Master for a few years to come. It will be important to observe those patients, particularly patients off therapy, for the following years to accurately report the risk of progression and the risk of MRD resurgence. I think it will be very interesting to see what happened to those MRD resurgences. I think there are other things we want to learn, for example, immune reconstitution and the interplay of immune reconstitution with MRD and with the risk of progression. However, in terms of clinical trial, I believe this sets the stage for start asking different questions for different subsets of patients. We understand the early MRD, particularly after induction, is a good separator of disease with a better biology that is amenable to treatment de-escalation. And I think of those patients we should explore in a randomized setting the omission of autologous transplant. But conversely, for patients who remain MRD positive, we need to explore new ways of consolidate that is not just repetition of additional cycles of quadruple therapy. And that's the direction we intend to go.